You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, the new treatment options for people that are in chronic pain, whether it's back pain, shoulder pain, knee pain, or neck pain. According to my first guest, he says that the majority of people on opioids, and this is a big statement, don't have to be, that there are newer treatment options available. He said to look for an interventional pain management specialist with us. We have an expert on the topic. In fact, he created this medical specialty, Dr. Manchikanti. Dr. Manchikanti, welcome to the program.
Thank you. Thank you again for inviting me to be here, and you spelled my name much better this time.
Okay, good. Thank you so much. We had you on the program before, and this is a very big topic. For people that don't know your centers, I mean, you have 14 plus centers stretched across a few states.
Four states.
So who's the typical patient that you see? And then I want to get into some of the newer things that you're using to treat pain naturally.
Well, typical patient is anybody. You could be my patient, and your neighbor or your wife or your children, anybody. So we have all ages, all patients. Chronic pain patients don't look any different than other patients unless they are really, really opioid addicted and unable to function, but they look normal. They have problems which is affecting their function, and they're not able to take care of their life.
Is it mostly
lifestyle.
back pain you're dealing with? Like, is that the number one complaint that you see in your centers?
If you take all the patients with chronic pain, 60% of the patients are chronic low back pain, and remaining 40% are neck, thoracic pain, joint pains, headaches, etc. That is, we are looking at the chronic pain problems. If you are just looking at the joint pain, that would become a major issue, or musculoskeletal pain. So musculoskeletal pain and spinal pain are pretty equally distributed. There was a study done in 2013 in United States. We spent about $90 billion on each one of them, a total of $180 billion. That is the accounted medicine. And then we have all these self-pay, over-the-counter medications and alternate medications which do not show up in the statistics. So what is recorded there is about $180 billion a year, for 90 for musculoskeletal pain and another 90 for spinal pain, which includes neck, low back, and mid-back pain.
Okay, now the things we're talking about today are really covered by insurance. Almost everything we're going to talk today, Medicare,
CHAMPUS, Medicaid, and almost all of them.
Now, before we came on the air, I was asking you, I was trying to put you on the spot. I said, are there really people that are on opioids that don't have to be? You said the majority. And then you went on to say almost all of them.
Right.
But they're on opioids for a reason. They're in pain. So how are you getting them off?
So the problem with this is that we don't understand pain properly. When you go to a doctor with acute pain, you sprained your knee, you went with an acute pain. So the easiest way for the doctor to get you out of their office is to give you some pain medication.
Okay.
So you take that pain medication, then you're hurting again after a couple months. You call the doctor, he gets you another refill. So you suddenly became a chronic pain patient, and you are taking more and more medication to help with your problem. You're developing dependency.
Okay.
So that is how this whole system has started. But if you took care of the acute pain, which was you developing immediately with the knee pain, without starting on opioids, it would have been much better. Or alternately, if I explain to you how dangerous this could be on a long-term basis, all the side effects, including immunosuppression and fatigue,
and constipation, everything else you were telling me.
Constipation and testosterone deficiency. All these problems, nobody wants to have a testosterone deficiency if it is a man. A woman doesn't want to have progesterone deficiency. So these are the issues. If you understand these things, they say, oh my God, I'm going to take on
But nobody wants to take, I'm sorry to interrupt, but nobody wants to take opioids that's on them, but it's the only thing that works for their pain. So you're suggesting, I just want to make sure I'm clear, that there are alternative therapies, and if you get them early enough, you could avoid opioids altogether.
That's correct. Actually, opioids, that is the total misconception that opioids are the only one which work. They do work in acute pain. They are the best thing in acute pain. And also in cancer pain, that's pretty good. But when you are taking chronic benign type of pain, what we have, you have pain which keeps going on and on with acute episodes. That is chronic pain. It is not cancer pain. It is non-cancer pain. In these cases, opioids are not the best. if you really...
Would you say, by the way, I just want to know, so I know,
Yes, sir.
Kentucky, are there like thousands, tens of thousands of people on opioids that in your opinion, and I know you can't prove this, at least exactly, but are there hundreds of thousands of people in the state that are on opioids that you could probably wean off?
Yes, I was looking at Jefferson County. In one county, they issued 270,000 prescriptions. So it is very common. We issue so many prescriptions. Once upon a time, all America, we issued 275 million prescriptions. They went down to 190 million now. And if you take Kentucky, there were 1,250 deaths in 2018 because of the overdoses. So where are all these people coming? They try opioids at one point, then either they overdose themselves or go into illicit market, and they go onto illicit fentanyl and heroin, and that leads to them to death. So if we treat the pain properly with other modalities rather than just opioids, you can improve their life and they make them productive citizens. They can play golf, they can go home, they can work, they can play with children. Those are most wonderful things, especially with grandchildren. So we treat chronic and acute, subacute pain with interventional techniques. This is identifying where the pain is coming from, putting the medication where the pain is with small needles and injecting medication. Then we use radiofrequency ablation. Also, we do the neuromodulation as we are speaking.
What does that mean, neuromodulation?
So we try to modulate their pain perception. So this can be done with intrathecal infusion systems like pumps, where we give small dose of opioid into the spinal canal, and that will help them as much as very high doses. Okay. So if you are taking 100 milligrams of morphine, let us say, in a hypothetical situation, I can control that pain with 10 milligrams of IV morphine. But with intrathecal morphine, where we put the pump in.
So you implant a pump.
Yes.
That delivers the medication in a small dose to where the pain is original.
It delivers 1 milligram all day, like one drop every few minutes. So that will help them. It occupies the receptors which are responsible for opioids, where they go and they have gamma receptors and kappa receptors. They go and occupy those directly. When we are giving by mouth, it goes through metabolism. It goes through your liver, first metabolism, and it spreads all over your body. By the time it goes to the receptors, there is only 1/100th of it. Okay. So here we are putting 1/100th directly there.
So look, knowing you're going to come on the show, and when I hear about implantable pumps for medication, that sounds like a real drastic approach. To me, right, it sounds like a lot of medication, but you're saying it's like 90% less medication when you get an implantable pump. I don't want to put words in your mouth, but is that close?
It is only 1% of what the medication you're taking, so really? It is 99% less.
So that means the side effects associated with that medication
absolutely.
Go away.
You will have less constipation, you will have less testicular dysfunction or hormonal dysfunction. Some people lose weight with it and they are functioning much better. But not all patients are candidates for it.
But for people that are candidates, right? And like you said, there's thousands of people that could be candidates for this procedure in Kentucky, right?
No, thousands of patients who are candidates for interventional techniques.
Okay.
So some of them are candidates for this. This is not the first line treatment, it is the last line treatment.
Okay.
Final treatment.
But it is somewhat, is it a routine procedure to implant this type of medication pump inside of a person?
You need special training to perform this, and you have to have experience, but it is a reasonably very safe procedure. It can be performed as an outpatient, and it requires a maintenance. You have to fill the pump every 2 months or so. So it will be delivering. And there are several medications now we can use. FDA approved medications are few, but at the same time, there are a lot of compounded medications. We can put them in there, and we can mix them, several medications, a muscle relaxant and a pain medication together. Okay. So especially if somebody has spasticity, those people, it is much
like
better.
back spasms, things like that?
No. Spasms like your arms after stroke.
Okay.
Or some kind of injury or spastic disorders or multiple sclerosis. Those type of patients, we can just give them baclofen. You don't
delivered with this system.
Yes, and you don't even have to give anything else. They don't need any pain medication. They just need this medication to maintain their spasticity or relieve the spasticity.
Do you find that people, by the time they get to you, that it's like not too late, but I think we talked about this in the green room, that you'd like to see patients earlier on?
Much earlier. Like on average, we did a study a few years ago, like I have done several studies, as you know. We did one, and the average time for the patient from the onset of pain by the time they came to me was like 5 years or more. And average number of physicians they have seen was same, 5. So they have seen multiple physicians already, and the average number of drugs were 5. They were taking multiple drugs. Benzodiazepines and opioid combination is pretty dangerous. They are indicated in few patients, but several of them were on several drugs together.
Okay. Who do people normally go to for their pain?
Who's
managing it for the most part?
They go to the primary care physician, and when they don't get better, then they refer them to a surgeon. Or sometimes if they have patients and evaluation, and if insurance requires, they will send them to physical therapy. They also go and get an MRI immediately, which is not a very good thing. They should never they should never get an MRI immediately. They have to wait for several weeks and see, and should not take the bed rest. They have to be active and moving around. So those are the things to avoid in the beginning.
You're head of a society, right?
Yes.
If you had it your way, would you like to reverse that, where the primary care physicians, and they're going to be watching this program, I'm sure a few of them will.
Yes.
Would you
I
love
have
for them
several of my friends.
So would you love for them to maybe get a consult with you, because you're going to go with a more conservative approach first? Is that fair to say?
That's
possibly?
correct. Yes, if they understand and send the patients to us, acute pain patients, some of them do. So that would be greatest thing. So we can assess them properly and also treat them properly from the beginning. Like if we treat them properly in the beginning itself, probably you don't need the intrathecal infusion system.
Okay.
Sometimes you need a stimulator probably, but not a intrathecal infusion system.
Okay. Now, we talked in the green room, and I had you on the program, I think probably 4, 5, or 6 months ago, and you said there's new things that we're doing today I couldn't even talk about on that first show. In fact, you said like a couple of weeks ago, you have new technology, new techniques to get rid of pain. What are those?
One of the things is spinal cord stimulation. You said we were going to talk about it more.
Yeah,
but
let's talk about that.
I just want to mention a few things. We got approved from January 1st, which we couldn't do last year when I talked to you on the show. These are the treatments available for knee, the sacroiliac joint, that is the joint which is between the low back and the hip, and the shoulder and the hip itself. These were not approved last year. Now they are approved, and most insurances cover those procedures. So if somebody is having a knee pain after surgery in a hypothetical situation, before there was nothing we could offer. Now we can do what is called a genicular nerve block. We can block all the nerve supply. After that, we can do the radiofrequency neurotomy, where we put the heat, so that can give them long-term relief.
Now, and I want to ask you this question about the spinal cord stimulation. And I think you helped me understand this a little bit, and I fully haven't wrapped my mind around it, but you stimulate nerves with some sort of electrical stimulation, and it changes the signal or blocks the signal to the brain, so they may be in pain, but the brain doesn't know they're in pain.
That's correct.
Is that kind of how it works?
Yeah, sometimes you can call it a pain pacemaker, heart pacemaker, just like that. It's a pain pacemaker. So in 1965, they came up with this gate control theory, where they said that there is a gate in your spine, and it controls the pain impulses. And there are 2 types of nerve fibers. One is called small nerve fibers, like C fibers.
Okay.
So they are the ones who carry the pain. Then there are other kinds of nerve fibers, A and B. They carry your sensation, pressure, and everything. So after the gate control theory, Sheely, he's still alive, so he figured out, let us see if we can block this. So he put
block the signal to the brain.
Right. Okay. How we can modulate it. That is how neuromodulation came.
Neuromodulation.
Modulate the stimulation. So what he did was, and another physician, both of them, what they did was they put the stimulator in and stimulated these large fibers. So when you
in the spine, these are all, we're talking about the spine, okay.
When you stimulate the large fibers, it closes the gate. So the pain from the small pain fibers does not go up.
To the brain.
Right. You're confusing the signals.
Interesting.
So that was the first theory, and later on there we developed more interest in it, and there are central mechanisms. Then there is dorsal root ganglion, how this stimulates, how the stimulators function better, but that was the basic tenet, how we developed the spinal cord stimulation.
So today?
Today, there are so many types of stimulator, you can't believe. Even from last 6 months, there are several more now. There is a closed loop.
This is like the holistic crowd, the people that go to Whole Foods that don't want to be on these meds. For some people, they don't have to have meds at all. Is that true?
That's true.
That you could just confuse this pain signal to the brain. Well, it seems like everybody would want that.
Well, not everybody's a candidate, and not everybody wants, because it is an invasive procedure. You're putting these leads in your back, and then you're putting a battery pack. So it is a surgery. So once you look at it, all the details of it, some people don't like it. But if you are in pain,
they don't like the idea of doing it.
Right.
Okay.
If you are in pain, you can't function, then you have to seriously look into it. Because you can be off of opioids, or if you are on opioids, like if you are taking 6 to 10 tablets or 100 milligrams of morphine equivalent a day, but your quality of life is low. You're fat, you can't function very well, you can't think very well, you're not able to do your job, you're not able to play with your grandchildren. Now, once you have the stimulator done, even if you're on 1 or 2 tablets a day, you're okay, but you're able to function. You're going to play with your grandchildren. You are able to do everything you want to do.
Are there hundreds of thousands of people in the state of Kentucky that could potentially benefit from this therapy?
Yeah, probably. So.
Okay. Now, logically, this makes sense. Now, also, you do like a trial. That means if somebody comes in, you test them to see if the stimulator will even work. How does that? Tell me what that's like.
Some of the requirements, these were established by government, Medicare, and all the other insurers follow them. Like before I was saying, for every procedure, you have to have indications and medical necessity. You can't just go and do because I know the procedure.
Right. Okay.
Sometimes I don't have time, but there is a Yo Mama test. You have to use that test here. So first you have to have first you decide if the patient needs it. Second, patient has to agree with it.
Okay.
The third, they have to have appropriate psychological evaluation.
Okay.
And there are no contraindications. Then we do a trial. Trial means we put the 2 leads into the spinal canal and leave it anywhere from 3 to 10 days. During this time.
How soon do they, by the way, get pain relief in the best cases?
Depends on the type of the stimulator we are using. If we are using a high frequency stimulator, it gives very high frequencies. They don't feel anything, actually. Just the pain relief is the only thing. They don't feel any stimulation.
Really?
Yeah.
Okay, so you've decided now that they are candidates for this procedure. How long does it take you to put it in? And you say in some cases it starts working in like 3 days, or immediately?
It takes about 45 minutes. There is a preparation. You have to have the sterile preparation and everything. And after that, you put 2 needles and to put the 2 catheters in there. And some of the systems, actually we check them when they are still lying down on the table, if they are feeling all the sensation or not. If they feel the sensation, then only we stop. But whereas for high frequency, this is the one you don't feel immediately. You don't have to check there. We just look at the anatomical position where it is properly placed or not. Then they start stimulating. So they start feeling a day or 2 or 3 afterwards, and then they start building up. So in those cases, sometimes we leave them as many as 10 days to get the proper relief so patient can feel very comfortable. In others, we take them after 5-6 days.
So for many of these people, spinal cord stimulation that blocks the pain signal in their brain is like a miracle for some patients.
Definitely.
Like it's a big deal.
That is the word they use. They actually say that, well, why didn't you tell me this all this time? Now I got my life back. I can think about it.
Really?
Yes.
Well, why didn't you tell them earlier?
Well, sometimes they don't understand. We do tell them, we try to. So many people, so many patients. I have a pretty busy practice, and so does a lot of other doctors.
Do you still see patients, or are you just the team? You have a big team?
We have a big team, but I see probably in my location, we have 14 locations. In my location, I'm the busiest physician.
Okay. Back to the spinal cord stimulator for a moment. And for people just tuning in, we're talking about being able to avoid opioids or heavy pain medication by getting an implantable device that stimulates and blocks the signal to your brain of the pain. You do these what? Once a month, every day, every week?
I would do on average about 5 to 10 a month. So.
Is that right? And the results?
Results
really good. If you choose to move forward, usually they're probably going to get results.
That's correct. My selection criteria is very strict, and unless a patient really wants it, they have to have a desire to get better. If somebody wants to be disabled, they don't want to function, they just want to be on pain medication and happy with it, that is not the candidate. Somebody wants to get off of the pain medicine, they want to do more in their life and function more, sometimes go back to work. I have patients, 75 years old patients, they're working again. They don't need to work, but they said, oh my God, I'm feeling good. There is nothing I need to do now. Let me work.
Is it fair to say that you're using all of the newer technology or all the latest stuff that's been approved to attack pain?
That is the advantage of being a major organization. So we apply the same principles to all the centers. We standardize everywhere.
Okay.
Every center follows the same booklet, information, the same type of evaluation, same type of documentation, everything is same. It is not a franchise, but almost like a franchise. You buy something, so they teach you to do the things just one way. We do that, but we still provide individual care. A patient decides, a physician decides what is required for each patient separately.
So if somebody's watching this and they're, at the beginning stages of chronic pain, they're going to their primary care physician, should they ask I know your thoughts on this, but they should ask their primary care physician, could I see a board certified interventional pain management physician?
They should. They actually should, because the doctors love that, because that is going to relieve the doctor of stress of managing this patient.
Okay.
How long do I have to manage? How long do I have to give the medicine? And they will be happy to do that if if a patient requests it. I have never seen a doctor refuse a referral. There are few cases, of course. But.
So, somebody's watching this, they're in chronic pain. They haven't really heard about spinal cord stimulators. They haven't heard about some of these implantable devices to lower their dose for medications. They can call you directly. They could ask their primary care physician. Everything we're talking about is covered by insurance.
That's correct.
Okay. And you're also getting involved in the wellness and putting people on anti-inflammatory diets, in certain cases even optimizing their hormones. So it's a complete pain center.
That's correct. We are understanding how important it is to have a holistic approach and treat the whole patient rather than a disease or one part of the body. So to achieve that goal, you have to do everything else.
Okay.
Sometimes they don't even have to be. Once you optimize the hormones, they don't need to be on pain medication.
Really?
Yes.
That's happened?
Yes.
Okay.
Many times.
Okay. So anesthesiology. So you're keeping people out of pain while they're asleep, or kind of like asleep. And pain management, what you're doing is keeping them out of pain while they're awake.
That's correct.
And they're able to drive cars, think clearly, get off the medications. And so back to the original thing at the top of the show, most people on opioids could be taken off of them.
Yes.
And still
or reduce
get pain
it to
relief.
a great level, very low levels.
And how often do you take people off their heavy pain meds?
Well, we are doing it quite a bit now than what we used to, and we are giving a lot lower doses, but we do that all the time. All these patients, we do spinal cord stimulations or intrathecal pumps, or even radiofrequency neurotomy patients. And important thing is diagnosing the pain, where it is coming from, what you are offering, a effective modality.
Okay.
And if you need repeat treatments, you keep doing them. But at the same time, you can keep them functional. Do something, what you want to do. I always want them to pick up 4 things. What are the 4 things you want to do? So I keep the note of that and then use them. You see, you are able to do all 4 of them.
Okay.
Now you are 100% there.
So whether that's golfing or running or back in the gym or whatever.
Yeah, playing with the grandchildren, children, or going to the ball games, or there are lots of things. It is fishing and hunting are more important things in my area. So
some people come to you to avoid surgery, and you have to be the person to tell them surgery might be the best way to go.
yes,
Is that right?
There are few cases where they do need the surgery, and that is the major advantage here. When we assess your pain generators, even if you didn't know that you needed surgery, I can find out if you need the surgery, and I tell them to have surgery. And believe it or not, when we refer the patient after all the workup and everything, they understand what it is. They do much better than patients who are going to have surgery just off the street or just referred through primary care. And so if they went through this process, they do much better.
Let me, one last thing, I'm going to put you on the spot, and I know you don't know this question's coming, but of all the people in the country that are getting fused, spinal fusion, how many of those in your estimation, this is purely an opinion, possibly could have been avoided with some of the interventional techniques we're talking about today? 20% of them? Half of them possibly?
Well, the literature ranges from 20 to 65%, so as many as 65%.
Well, that's
some
big.
people say that
Can be avoided.
avoided.
Okay, good. And people wait too long to see a pain management specialist?
Yes, that is the major issue. They think that, oh, I'm not there yet. That is a chronic pain problem. I'm not there yet. I'm not there yet. Doctors don't think, no, we don't need to send to pain management center yet.
So, shoulder pain, neck pain, back pain, low back pain, sciatica, this is everything you do.
Yes.
Using all the newer technology and trying to get people off of these opioids.
And also improve what they like to do, like quality of life, but that is a broad word.
Do you ever get hugs from patients?
What?
Do you ever get hugs from patients?
Oh, a lot of them.
Really?
Yes.
They say it's like a miracle. You said that they call it a miracle for some people?
Yes, they are very grateful. A lot of patients actually are grateful that you are listening to them. Taking the history, you sat down and sat with them. Nobody did. Gave a prescription or ordered an X-ray. So
when you're talking to a patient, in your mind, you're on the consult, you've got their medical history, is your goal like thinking, how do I get this person to avoid medications or slowly wean them off medications? Is that going on in your mind?
Oh, yes, that is our fundamental goal there. How can I find out what he is suffering with? How can I manage with least medication or no medication?
And that's what interventional pain management physician does.
That's correct. So.
Okay, good. I want to thank you for coming on. Always a pleasure, Dr. Manchikanti. So appreciate it. And if they want to make an appointment, they just call your office. You guys are taking all types of insurance. So thanks again.
Thank you.
You've been watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. For now, I wish you good health.
Thanks for watching the Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.